Okay, so why don't we break over to Dr. Avula and Dr. John Satish in Vijayawada?
Yeah. While going back to that, the first question, which imaging? Suppose the vessel is diffusely diseased, small vessel. We have to push the dye into that one. Which one will be the better in imaging modality?
You can go forward.
Whether it's a 22.25 millimeter vessel diffusely diseased.
Yeah.
No distal runoff.
Exactly. So I think we'll just have to see what the distal runoff looks like prior to making that decision. Okay, so let's go live to Dr. John Satish and Dr. Surendra.A in Vijayawada. Hello, sir. You're live. Thank you for joining us.
Are we live?
I'm Dr. Srinivas Kumar here, sir. Dr. Surendra.A, sir, can you hear me? I really thank you. He's actually cardiologist in US like you, and he volunteered to do everything because a lot of experience in orbital atherectomy. So we wanted somebody quite experienced. He readily agreed. And this NRI Medical College is another good college coming up in another Telugu state, Andhra Pradesh. Thank you, Dr. Sir, and over to you for your presentation. Thank you.
Thank you, Dr. Srinivas. All right, you're live, sir.
No, thank you very much. And can you guys hear me at all?
We hear you really well.
Well, thank you so much. Thanks for the opportunity. And here there are a lot of extremely experienced people, including Dr. John Satish, who is our head of department, along with Dr. Gopal Krishna and Dr. Dharmateja and Dr. Krishna Prasad, along with Dr. Radhika were there. And Dr. Radha, who is one of our fellows, will present the case scenario quickly, and then we'll move ahead. And again, thanks again for the opportunity for this great endeavor for us. And we'll start in a second there. Go ahead, Radha.
Good afternoon. I'm Dr. Radha from NRI Medical College. Today, I'm going to present a case about a 72-year-old male who's a diabetic, hypertensive, and a dyslipidemic. He presented to us with unstable angina. He's on guideline-directed medical therapy, and he's a poor responder. He had a history of PCI to the left circumflex 14 years ago. This is his ECG, which is essentially normal. And his 2D echo revealed normal LV function with no regional wall motion abnormality, and his ejection fraction is around 60%.
He's in good medical therapy, but presented with unstable angina. So we already completed the OCT, which I will show you also. Is and we'll show the angiogram.
Can we see the angiogram?
Yes, it's coming up.
Can you show the angiogram, please?
Is the angiogram being shown there, please?
Yeah, maybe start with the angiogram and then we can
that's
see
what it's playing here for us screen wise. Yeah, it should be there now. Yeah, right.
Perfect. We can see the angio now.
Wonderful.
Okay, so
The radial approach, 6 French guide.
So well, obviously we went radial with 6 French guiding system here. This is the OCT we completed already also. That's why you got to see the 2 wires just in case. But in any case, now we introduced our guiding catheter with, I was able to primarily wire with the wiper wire with the flex tip without any problem. And it's a great wire, I think, in general for wiring the lesions. It's almost behaves like a standard wire, and we're very happy with the wire. We have been using it for a long time. Any comments or suggestions with the calcium, what you see? Obviously, you're looking at the train track appearance of the calcium there. And there is a lesion extending from the ostium of the LAD into the mid portion of the LAD system also. Any thoughts or concerns, questions at all for the panel?
Your choice of calcium modification here was orbital atherectomy. Why not in rotablation? My questions.
Well, let's go through the OCT perhaps, and then we can discuss on what the strategy might be. So, so would you take us through the OCT on what you found, and then I can poll the panel on what our consensus is and what your plan is.
Sure. Second one. What is the second one?
Second one.
You can stop anywhere you want to.
All right. So what do you think?
Can we have the vessel dimensions, please?
Yeah.
It's good. 3.5. It's a bifurcation and the ostium is also diseased.
Exactly.
So we have a 3.5 vessel, which is diffusively, extensively calcified with large chunks of calcium, and the ostium is also diseased. Yeah, then I guess orbital atherectomy would be one of the choices, because as compared to aorta, it's a bigger vessel. It's got an ostial disease, which we can cut both ways while going in and coming out. And such a large vessel, rotablature may not just work. So I guess from seeing the OCT and the angio orbital atherectomy, definitely looks like a good viable option to me.
If I may interject, in the first run, there is a calcific nodule also. Obviously, it is not an eruptive nodule, but it is, you can say, nodular calcification. It's a calcific nodule you can see. That's where you just finished there, the calcific nodule. You can go back again to show that. So we thought, given this context of the larger vessel plus longer lesion along with the calcific nodule, we thought orbital atherectomy will be the appropriate choice for the interventional aspect of it.
We agree. Given the vessel size, I think you will get a better result with orbital atherectomy here.
What about ostial lesions? Ostial lesions, is it better to mostly keep it?
Yeah.
Any comments?
Any other comments or concerns or questions? Then we'll proceed.
No, I think the panel agrees with your decision that orbital atherectomy is certainly very reasonable here.
So as we can focus upon the table here, the device is there, and you can see we're already has wired it, as I mentioned, and we are all ready to go. And I'm going to show the crown here, and hopefully you can see it from the camera angle also. Obviously, as all of us know, it comes in only one size with 1.25 millimeter. And I am not a big fan of 120,000 RPM. I'm generally try to stick to the 80,000 RPM. And we already tested the device. So we're going to move forward into the vessel. And
perfect. And for those in the audience who haven't used orbital atherectomy, can you just show a little close up and what the setup looks like?
It looks like.
Good. Mr. Prasad, camera and tilt it. Oh, yes. Let Surendra, you show.
Yes, these are the buttons that you can see. This is the knob, which is the control knob to go back and forth. And these are the speed controls there. And this is the flushing device. The first one is the 80,000 RPM. The next one is the 120,000 RPM. This is the most important aspect of the device, which is the brake control. And obviously the wire exiting, you can see. There are two connections. This is the wiper slide flushing through, and obviously the power connection, as you can see with the black cables there.
Thank you. Yeah, the overall setup is similar, but even simpler than rotational atherectomy. So this comes a slightly more pre-packaged. All right, go ahead, sir.
Just a point to note is that the lubricant solutions in both have got egg yolk, soya bean oil in the orbital atherectomy, and olive oil in the rota. So you just have to be sure that the patient is not allergic to any or all of the above before you start using either of these devices. Not commonly done, but one should check for allergies before these infusions are started.
So while he's waiting, the other use that we found for this Viper Rotaglides, Viper Glide has been in structural cases when the groin vessels are really tight. So we've actually used that in the sheath, and then the valve goes a little simpler.
We're already near the lesion there. Also, if I may make one point too, if somebody is allergic to egg, but not allergic to the soya bean or so, then we can use the regular flushes also to do rotational atherectomy. If they're absolutely allergic to egg, then obviously orbital atherectomy will be out of the question. It has to be rotablation if we absolutely have to do that. So as you can see, the nose comb is right at the lesion, and obviously the crown is at that point, and right we are in the middle of the calcium. What I can do is I can do two ways. We can go, as everybody knows, it's a bidirectional atherectomy. So because the sanding can be done both forward and backward motion along with the pulsatile forces, meaning as it is rotating through the orbit. So I'm going to use the the glide assist just to make the device go just forward a little bit, and then I'll come back in a retrograde approach, which is actually, in fact, my favorite approach to do.
Yeah, and that's the key difference between rotational and orbital atherectomy. In rotational atherectomy, the diamond burrs are on the leading edge. So whereas in orbital atherectomy, you can go back and forth and you're ablating in either direction.
I just want to show one more thing on the device. When we're doing that, if I press this button, you can see it is flashing. That's the glide assist. So we press it again, then it becomes constant. Then that means it is ready to use. And also you can see there is enough gap there. So I can come backwards there so that I can ablate both backwards and forwards there. I already crossed the lesion, as you can see. Then I'm going to just come backwards now.
So in my life, I've had several rota burrs that have been stuck. Anybody had experience with orbital burrs being stuck?
Yeah.
I've not
Same
had.
question.
Yeah.
Did you have any experience with this orbital atherectomy having a stuck situation wherein you're not able to come out?
So far, actually, because of the very nature of the device, we did not have that experience, luckily, and thank God.
Has it been described? Has it been described?
It has been described. Yes, it has been described. And I think it is mostly because of the technique. That's what at least my perception about that is. Because obviously, as everybody knows, the rotational atherectomy wise, once we take a smaller device, the chances of, because of the friction coefficient being lower, so it gets stuck there. But I think the chances are very much low, but it has been described. Absolutely.
I mean, I personally have not experienced the orbital being stuck. Rotational, I've had a couple of patients where it was so stuck that I had to send them to the OR.
The burr entrapment is very less likely. Even if you move forward, okay, beyond the tight lesion, you can pull back and cut because reverse cutting is there. That's the reason. But still, because very tortuous, very tight calcium, sometimes the reports are there. But relatively, compared to rota, the entrapment is, burr entrapment is very, very low. The another one is slow flow is very low, and no flow is very low. And because the central forward flow is maintained, because it moves along the artery circumference, whereas the central movement, rota, it will not allow the forward flow. Another one, debris is also very, very small with orbital, almost 2 microns versus 7 to 10 microns. So slow flow, no flow less, and even single burr, single crown, by increasing the speed, velocity, then you can increase the ablation area. That is the advantage. If you want to do the rota, you have to upsize the burr. Here, no need. Just increase the speed and you can get the bigger ablation. These are the advantages of the orbital atherectomy over the rota.
So the lesion characteristics are totally different for a rota and for a orbital atherectomy.
Yeah.
The smaller the vessel, the longer the lesion, you go for a rota.
Yeah.
The larger the vessel and diffuse lesion which requires cutting both ways, you go for an orbital atherectomy. You go for an orbital atherectomy in a smaller vessel, you will cause ischemia because you're going to do it very slowly. You're going to have no flow while you're doing a slow or orbital atherectomy.
Do you think in this vessel we can go distally?
Both sides it happens.
Do you think the distillation can
What I'm
be done?
doing now is I'm coming back retrograde slowly, as you can see, and it can ablate backwards also. And just to add another point to that, because the blood flow is rather continuous, the heat generation in the vessel, at least theoretically, is less in the orbital atherectomy there. Also, if you, I don't know whether you can hear the pitch sound there. I'm looking at the clock. I run generally about 20 seconds there, each run, and we stop. And one of my habits always has been is just have a small 1 cc injection just to make sure things are okay and it looks good. That's all I need. And I'll give it again the same run, whatever the length of the run is, I give the break for that between each runs there. What we looked at is about 30 some odd patients there. We made about 3 runs. And then we did the OCT again to see. Essentially, every time we have seen the fractures, both intimal ruptures along with the fractures, we have noticed that in our practice there. So generally, we do about 3 to 4 runs at the most. The one point for the novel users, I would say, is for the new users, I should not say novel, but new users is make it shorter runs, like 20 to 25 seconds at most, but you can do more runs rather than longer runs there. So shorter runs, but more runs there. So we'll do one more run.
And that is a really good point to prevent ischemia. And then I think that the technique of just taking a quick puff to make sure you don't have either a flow limiting dissection or a perforation, although the chances of perforations here with orbital atherectomy are fairly low, but still not impossible.
Just for the audience, what is the smallest caliber of vessel to which you can go up to with your orbital atherectomy?
The smallest generally would say is about 2.5 millimeters minimum. That's obviously the requirement to do that. Less than 2.5, we should not use the device because of the orbital nature of the device itself.
So you finished your 4th run, or you just starting?
I'm doing my 3rd run now there.
Yeah, I think
and slowly, the key is here is when compared to rotablation with the pecking movement, this is rather slow motion.
So Dr. Avula, what we'll do is we'll let you finish up this orbital run and maybe repeat the OCT as you were planning, and we'll go back to our first case to see how things are going there and maybe rejoin you back in about 10 minutes. Does that sound like a good plan?
Yeah, absolutely. Thank you so much. We'll see you
Perfect. Soon. So Doctor, well, we'll get back to that, but let's check in with Dr. Avula on, so after the orbital atherectomy, what was the next progress?
Yes, what we're doing now is I already put a BMW there because I want to do the OCT, and I'm going to take the wiper wire out, and we're going to redo the OCT now. What I want to show you is a couple of things there. We can play the last run, please. Last run of the OCI. No, forward, please. Forward. Yeah, this is the retrograde approach, actually, as we talked about, this, and we went to the mid area of the LED, and we're able to carry out the orbital atherectomy again, so that we can carry out a mid segment. And I'm going now on the BMW, bring it. To the optical coherence tomography to see what we get, and then we can show.
So in the proximal vessel, did you use a higher rotation, or it was just 80,000?
But I am not, as I was mentioning before, not the biggest fan of 120,000 RPM, because in my, at least, my experience, I think I got a reasonably good experience. It has been, I think it is more complications related rather than helping a lot there. But, obviously it is a 4 millimeter vessel, then we have to do 120,000 RPM, but I rarely ever do that. There is a 3.5, and I think I can get away with 80,000 RPM. And that's what I did.
The advantage of 120.
So we are right near the end of the lesion there. So we're going to do the OCT run.
120 or 80.
And also, I just want to make a point there too, is I think the slow motion is the best way to do that. As we're talking about, we also pay attention to the pitch changes, how the audio changes there, because, once you get used to it, you can see the calcified, that the grinding thing actually improves there and becomes much more softer. And obviously it takes some getting used to get those kind of listening stuff there, but that's one thing that the new users should get used to. Now we're going to the OCT run post OIS.
We're excited to see the OCT run.
I already see what was done there, as you can see in the run, and I will try to stop it somewhere. The gentleman handling the machine can do that. The classic OIS cuts, what we call the semi-lunar, almost like a cup-like cuts, you can see that, especially that's a trademark for the orbital atherectomy. You can see those, go back again, one frame, couple of frames, go back, go back, go back, go back, go back. You can see those marks there. So those are the classic cuts, especially between 12 and 1, you can see, and also you can see how the intimal cut it hasn't happened there with the orbital atherectomy, how it is. So this is very classic, that's what you see the orbital atherectomy when compared to any other atherectomies there. And also you can see even the 12 to 1 o'clock and also 3 to 4 o'clock areas too, you can see the cut. And I think that 3 to 4 o'clock area is where the previous calcific nodule was, and we're able to ablate it. And that's one of the interesting points about that is so that you can do the ablation thereby in contradiction to IVL. And I think this is where I always prefer to use the device, this type of device, so I can ablate the peak of the mountain rather to say that way. And so that we can expand the stent better there. Also, you can see the cuts again, you can appreciate those between 11 and 12 and all those. And all, it is nice intimal cuttings were done. And also we're almost up to the calcium. And I think we got a very good result. And in a second, we're going to see whether we can put the stent into up to the left main and then post dilate and do accordingly. Any other concerns or questions or comments, please? There.
Would you regularly post dilate after the orbital atherectomy with the
yes, please. I do that routinely. Yeah.
Yeah, no, this looks like a great orbital atherectomy result. And I think you have ablated in exactly the areas where you thought that this would help. So that was a very good choice. Maybe what we'll do is we'll let you finish up with the stenting and then come back and see the final result while we go on to our next site. Does that sound okay, Dr. Wu?
Oh, absolutely. Thank you. Well, we'll see you soon. Yeah.
Okay, see you soon. And great work there. Okay.
Hello.
So we're having some problems connecting to Pune. So Dr. Avula, we're back with you since you're doing such great work.
Right. We are post dilating, pre-dilating or post OAS dilation, pre-stenting.
We can't see the angio screen. And what size stent did you choose, sir?
We're up to 12 to 14 atmosphere there. We're dilating now prior to stenting.
What was your stent choice?
We're going to use, I think, the Zions, Alpine. And we got, I think, in the lab, they had the 30 by 38 we're going to use.
So, Dr. Surendra, I have one question for you. Sometimes when you do a rotablation, we are not happy with the stent, the fraction, the calcium and the plaque modification. We use a lithotripsy balloon, IVL, for further plaque modification.
Sure.
Did you have a situation wherein you've done an orbital atherectomy, you were not satisfied and you had to use an IVL?
It is, I think in general, at least we rarely did that. I'm sure probably I have done maybe 1 or 2 cases in that fashion. But generally, as as a general rule, I did not have to do that there. But I think again the key is, and I'll go back to the same statement I made before, the technique. I think the slow and a very deliberately slow motion, like 1 to 2, 3, 4 millimeters slowly, and then I think we get very good result. That's one of the things that I find that once we have these intimal fractures, then obviously the delivery of the balloon or the stents will be much more easier.
So our next case from Pune is going to be rotatripsy, wherein you're going to use a rotablation followed by an IVL balloon. So the cost tremendously goes up when we use two devices.
Absolutely.
This is a situation wherein if you have one orbital atherectomy, probably the number of devices can come down, and probably if you can avoid an IVL, the cost would definitely be much better.
Absolutely. There in the economical analysis, actually, when we presented actually in one of the meetings in Tokyo also a long time ago, because the average amount of rotational atherectomy is about 1.3 to 1.4 bursts versus one orbital atherectomy crown. In that sense, I think it is a money saver also. Obviously, if we add IVL into the mixture, then we're looking at an exponential financial burden. But that is something that obviously, and I don't know whether we can solve that issue, but at least. And to go with the stent.
Dr. Avula, one question for you.
Yes, please.
Every orbital atherectomy, do you routinely image? If so, do you do it after the atherectomy or after the NC dilatation, and why?
Right. In my opinion, actually, the way, when I always, obviously, the one, fundamentally, any atherectomy should not be done without imaging. That's my, you can call it bias, but that's the rule I live by. Any atherectomy has to have a pre-imaging modality. And as I said before, in our institution, we looked at post-OAS atherectomy OCT also. Now we know how it looks. So a lot of times I may not do the post-atherectomy run unless I'm looking for something special. But obviously we image again once the stenting is done completely. Interestingly, if you see that some of the craters, we can call it, those semilunar cuts we made, you can see them again post-stenting also. That at least not all of that, but at least you can see some of them. That has been our experience behind the stents.
I think imaging is mandatory pretty much after any calcium modification technique. It has several advantages. So in our practice, we actually would try to pre and post image.
Excellent.
I don't necessarily image it between post stenting for sure. And then if I have any doubt, then at least even between the two. So 2 runs and maybe 3.
Apart from the vessel size, is there any difference in choosing between our rotational atherectomy and orbital atherectomy?
So balloon uncrossable lesions.
Balloon uncrossable.
Is one situation wherein probably I would go with a rota rather than with a orbital atherectomy.
Ready? So I think, Dr. Avula, we're ready with our next site. So we're gonna drop off here. And then if we have time, maybe we'll swing back to see the final result.
Wonderful.
Now let's go to Vijayawada with Dr. Avula and check in on how they are doing with their PCI. I think.
Yes.
No, Dr. Avula, you're.
Yes, we are back there. What we're doing now is we stented the proximal LAD, obviously with a 3.5 by 15. And then the mid to distal mid LAD, we dilated after the 3.0 by 38 with a 3.0 balloon. And then we put in a 3.5 by 15 in the proximal into the left main across the circ. And we did the part with a 3.5 and just the ostium and the left main with a 5 millimeter balloon. As the based on the OCT, it is about 5.5, 5.7 range. So at least we'll get at least 90% of the luminal area of the based on the OCT. And now we just finished the flaring near the ostium of the left main also, and we'll do one more flaring. So then, go ahead, please. Just hold on. Down there, and then we can do the OCT run, and then hopefully we'll be done with it. The circumflex looks fine. We didn't do anything for the circ per se.
Show the angio.
Yeah, I'll show you the angiogram, in a one more angiogram again.
No, they did the angiogram. Show that.
Can you go back to the angiogram, Balu?
Flow, stop flow.
Go ahead, play the angiogram. Go ahead, back to one more picture. One more. Yeah. One more. Right, yeah. Go ahead. Angiogram.
Next.
And we're taking one more angiogram.
So far, we see the inflations.
It's outside.
Maybe we can see the final pictures after you've done all the.
We're going to do the one more CT round and hopefully we'll be. That's the picture there. Now the left main and the LED.
It looks nice.
Right. Thank you. And we're going to do the OCT run.
And I don't know if we will have time to see the OCT run. Maybe we can come back, but angiographically, that looks really nice. I don't know if the rest of the panel has any comments. Everybody is nodding their heads. Well done. Congratulations.
Oh, thank you so much. Well appreciated. Thank you.
All right.